At the offset, thank you everyone and thank you for having me here. I'm going to touch upon the topic New Horizons in Genetic Testing. So, genetic testing has been used in several manners as of now. It helps in early diagnosis. So, for example, to differentiate between a retinitis pigmentosa, if tested early enough, whether the child will develop hearing loss or not when they come back positive for Usher syndrome. And we know that whole significance because if the hearing loss is tried to be corrected with a cochlear implant early on, it works better than later. It's also being used to prognosticate. So, for example, in AIOS2025 has been shown in the Saudi groups and now in Indian groups as well. In the CYP1B1, they have intractable glaucoma that need multiple surgeries. So, there's that precise genotype-phenotype correlation that's being used. And in planning treatment for children and adults, for example, RPE65 coming back positive, then there's the Luxturna gene therapy that becomes available. So before we jump into the new horizons, the evolution of genetic testing and what we have known. So a child like such shows up in the clinic and they have a cloudy cornea, but they also have this atypical facies with the downward slanting palpable fissures, mongolite slant, tongue is out, and typical down facies. So we ask for a karyotype which checks for the numerical and structural defects in the chromosome. Now, Down syndrome is very easy to diagnose phenotypically, but why should we do a karyotype then is also because of the possibility of a Robertsonian translocation in which essentially the third extra chromosome is stuck to one of the other chromosomes, and then the recurrence risk for the patient's parents changes significantly, understanding whether it's a free trisomy or not. Then there's first generation sequencing, also known as the gold standard of sequencing, which is Sanger. It is, as of now, only being used for genes that are very small and can be covered all together in one go, or for parental testing. So you have carried out a next generation sequencing test and you want to confirm the presence or absence of the variants in the parents. So a targeted location testing can be done with the help of Sanger. So from there, we move on to next generation sequencing, which we all utilize in our clinics every day, which includes tests like whole exome sequencing and whole genome sequencing, which is now getting into the clinics as well, but has primarily been used in research. And reports of it look like such. We get pointed genetic variations, where exactly in the exon, what kind of mutation, what is the classification of the variant that's found, what is the disease, and what is the, and also sometimes, like in this particular case, you can have incidental findings that can also be reported. Another test that can also be done is polygenic risk score. So this is what it looks like. These are for complex disorders that do not have Mendelian type of inheritance. So you do not have your 25%, 50% risk in the absence or presence of a variant. It's basically a complex of multiple polymorphisms that together give you a risk score. So it can be anywhere from 60%, 90% or lesser that make you likely or predisposed to a disorder. And then there's also multi-omics approaches that are entering the clinic now, which also use transcriptomics and proteomics for deeper insights. So, for example, in retinoblastoma, earlier we only needed to see the RB1 gene to understand whether it is a heritable form of retinoblastoma or not. But now there are markers like TIF1 that have come around that give us more information about how the retinoblastoma is going to behave. But why do we need more techniques than what we already have, and what are these new techniques going to do? So in a setting like ours, like in India, we do not have a centralized healthcare system and all the costs are borne by the patients themselves. So when we get an NGS negative and we are hell-bound that there is going to be a genetic variation that we have just not caught, we move on to do a chromosomal microarray. All of these costs are all of these tests are high-cost tests and have to be paid out of the pockets of the patients themselves. They lack spatial resolution and they're a sort of a real-time snapshot of what's happening at that time in the genome of the patient. And there's challenges with variant interpretation. As we know, most of the data that we receive and the classification of these variants that we see is based on the literature from the Western population. So VUS, or the variants of uncertain significance, is seen in our reports more than any other. And also that these these techniques are invasive in terms of we need to, in some cases, get the tumor biopsies or a tissue sample to understand deeper about the genetic makeup of that particular disease. In the interest of time, I'm only going to talk about very few genetic techniques that are now making their way and translating from bench to bedside for us. So one of them is liquid biopsy. As the name says, it's a surrogate for going right into a tumor or a tissue sample by using liquid samples. So this could be a blood sample, this could be a plasma sample, it could be CSF samples and such. And it's a non-invasive technique. There is less risk in it and less pain, and it's easy to repeat these. And what you do with this liquid sample, you could isolate what are called circulating tumor cells or circulating cell-free DNA, which is essentially when at the site of origin, for example, if there's a tumor and it lets go of tumor cells and the cells burst, they let out DNA that enters the main bloodstream. So this can be isolated from your genomic DNA and be studied. And there are exosomes that can also be isolated. And this technique has been used actively in in ophthalmology. So in retinoblastoma, Jessie Berry's group in LA has been working on it for over a decade, and she's been taking aqueous humor taps and trying to prognosticate how certain retinoblastomas will be either more aggressive or less aggressive. Our group is trying to standardize this for plasma samples and CSF samples to understand at different time points when a tumor is going to be, how it's going to behave. It has also been used in other malignancies like uveal melanoma. There are biomarkers in glaucoma that are being studied by this technique as well. The other technique that Dr. Neil already spoke about is spatial transcriptomic that's really coming around. So essentially, if you were to imagine a 3D model, suppose, of a tumor, this technique allows the gene expression profile within the tumor sections. So if there were, the hypothesis is, for example, I'll take retinoblastoma, that the tumor originates from the retinal layer of cells and then it proliferates and it starts to get calcified at the end where it started and starts to let off vitreous seeds and it starts to go into the choroid. So some signatures are apparently going to be different in each area. What is making the tumor go either backwards or forwards and making it into an extraocular tumor? And now we have the ability to study all of this. And why this becomes important is because with the help of spatial transcriptomics, you can also get answers like cell of origin, which then becomes important to understand what kind of therapies can come around and what kind of answers you can get based on this information. The other test I would want to talk about is optical genome mapping. This is a non-sequencing imaging techniques that identify structural variants. So essentially, you take very high molecular weight DNA, you enrich it with 6 base pair probes that repeat themselves every 200 base pairs, and they go and attach by a covalent bonding to your heavy molecules, and then you put it into a cartridge for scanning, and the chip essentially linearizes each DNA strand and it makes a picture like such. So it only gives information about structural variants. And why this test becomes important, because when we are deciding testing protocols for patients, for example, you have a child who has a small chromosomal variation, copy number change, for example, a small deletion. Karyotype, even silver banding karyotype, has its own limitations, and then chromosomal microarray has its own limitations. Chromosomal microarray will not give you information about the structure of the chromosomes, and if the parents are likely to be carriers of balanced translocations or balanced. So this technique is sort of filling that gap now, where those very micro deletions or duplications that the parents could have in the form of translocations can also be picked up. Yes, and then not to miss, AI in genetic testing is also making its way. How in genetics we expect it to come through is, so all the biobanks and all the repositories that we are now making, the kind of registries we are trying to develop with the help of genotype and phenotype, we will give access to AI and try to develop algorithms that will help in developing machine learning models. And then the first lacunae that I spoke about, that we get a lot of VUSs, we will get better chances of converting these VUSs to either benign or likely pathogenic or pathogenic variants, that process will get much faster, probably without the need for functional studies as well, just with the use of AI training models. And they will help in improving the diagnostic and personalized medicine. Because AI will enter mobile apps as well, one of the problems in India is accessibility to healthcare. So if something can be, if complex disorders can be diagnosed with the help of mobile apps, they can be made available to rural parts of the country. Of course, there are concerns about data privacy and regulatory compliances that need to be kept in mind, but that's to be taken into consideration later. So I want to finish by saying that genetic testing is no longer about diagnosis, it's enabling precision medicine. Multi-omics and AI is getting integrated into the healthcare system, and like Dr. Ken also said that for all of this to really work out, there should be collaborative efforts of working together with the clinicians, geneticists, researchers working hand in hand. So let's embrace this tomorrow. And this is a tiny team that we work with every day, but there's an army of scientists and clinicians at Shroff's always supporting us. So thank you so much.